Welcome, everybody, to our last official Woo You event of September, and it's going to be a good one. My name is Dr. Stephanie Woo. I am the founder of Woo University and your host for this evening. And now it's my pleasure to introduce Dr. Jason Jedlicka. Dr. Jedlicka is a residency and fellowship trained optometrist, having completed a residency in cornea and specialty contact lenses at Pennsylvania College of Optometry in 1997, as well as a fellowship in anterior segment disease at Minnesota Eye Consultants in 1998. He was the chief of the contact lens service at the University of Minnesota Department of Ophthalmology from 2000 to 2010. He's also served as clinical adjunct faculty for Pennsylvania College of Optometry and Illinois College of Optometry. He is a past president of the Scleral Lens Education Society. That is where I first met Dr. Jedlicka, and we've been good friends ever since. And he's also a fellow of the American Academy of Optometry, a fellow of the Scleral Lens Society and Contact Lens Society of America. He is the new chief of the Cornea and Contact Lens and clinical associate professor at the Indiana University College of Optometry. Dr. Jedlicka is not only an incredibly smart person that I know that I always learn a ton from, but he is a very highly requested speaker. I know a lot of people on this call tonight really wanted to hear from him because everybody wants to know what Dr. Jedlicka has to say. So it's a pleasure to have you, Dr. Jedlicka, and take it away.
Thank you so much, Stephanie. It's great to be here. And thank you guys all for showing up tonight. Hopefully this next hour will be interesting and eye-opening. And I don't know, this is not my typical topic, but I took the challenge because it's something that I think is of concern to a lot of practitioners, especially those who fit specialty contact lenses and sclerals, but not just sclerals, corneal GPs as well. And I think there's some frustration out there sometimes about wettability of contact lenses. And so not only did I try to bring my perspective, I did a lot of back learning on this myself, and I think I'm better off for it. I hope you guys will be as well. So we're going to talk about improving and maintaining wettability in GP lenses. I do have some financial disclosures, as this is part of a COPE-approved lecture. So to start off, let's make a definition here. What is wettability, or wetting as it's also referred to? Well, wettability is simply the ability of a liquid deposited on a surface to spread out and maintain contact with that surface. So a lot of different types of liquids, a lot of different types of surfaces. We've all seen contact lenses like the picture in the upper right, where we've got poor wetting because the tear layer is just pooling up into little areas where they are more comfortable being with each other, the molecules, than they are spreading out over that contact lens surface. The bottom diagram shows us the spectrum of a poor wetting surface all the way up to an excellent wetting surface. We see what happens when we have good wettability. That liquid is going to spread out over the surface over a larger area of the surface. So again, what determines wetting or wettability between a liquid and a surface? Well, first of all, a surface itself has surface free energy. So this is energy at the surface of the material. Now, inside the material, off the surface, the molecules are all arranged in a very specific way. But when we get to the surface of any type of material, those molecules are only going to be attached to other molecules behind and on the sides. They're going to have free anchor places or anchor points on the surface of that lens. And the ability of that free energy is often set by the internal structure of the materials and the molecules. And so things like metals, where the bonds between the molecules are really strong, or glass even, you're going to have a lot of high surface free energy. And so when we put liquids on metals and glass, they tend to spread out rather readily. Polymers, plastics, things that we create, and for better or worse, what our contact lenses are made out of, our GP lenses, tend to have low surface free energy because the bonds between the molecules are not that strong within the material itself. And so when we have weak bonds within the material, we tend to have less available energy at the surface to bond whatever liquid might come into surface with it and spread it out. Again, you can see by the little diagram on the right, when we have a lot of surface energy, we have a lot of anchor points for the liquid to connect to that surface. And when our surface energy is low, the molecules don't have a lot of anchor points for that liquid to grab onto. So the molecules tend to stay clustered up with the similar liquid molecules, or they will bubble up. So again, water itself has a high surface tension. And of course, a low surface tension is actually what we're after. So that's why water often beads up on surfaces. Now, the good news is that human tears have a lower surface tension than water does. So the oils and the mucins that are in the tear layer of the eye help to create a lower surface tension. So natural tears will spread more readily over a surface than water does. So if we're comparing water on a surface of a material, we have to keep in mind that human tears have a lower surface tension, which is good for wetting. So in order to improve surface wetting between a liquid and a material, we can increase the surface free energy by making the materials differently, the polymers differently. And so we know, for example, that GP materials have wetting angles. So this is all measured, right? But the reality is how much of a difference does that really make? I mean, really, these are still just all plastics of similar polymers, silicone and fluorine and different molecules that are combined to make these. How much of a difference does the material, the GP, really make? How else can we do this? We can alter the surface of the material. We can put a coating on the material that can lower the surface tension and create a situation where the water or whatever liquid can spread more readily because we've created a different surface energy to that material, to that surface. So that's something that we can also do. We can clean a lens material really well because a cleaner material, a more homogeneous surface, will allow liquid to spread more readily than one that has got deposits and things that create an irregular surface. And then we can also lower the surface tension of the fluid by adding things, lubricants or surfactants will create that. So the little picture on the bottom I thought was great. You have this little water blister, if you will, on the left. And by simply adding one drop of a surfactant, that immediately spreads out to a larger surface on that surface. And that's because surfactants lower the surface tension of the liquid that they're added to. So surfactants are a good thing, whether we put them in our eye in the form of lubricant drops, or if our lenses are coated with them as we apply them to the eye. They are also things that help with surface wetting. Why is wettability important in contact lenses? I think it's pretty clear. A non-wet surface, really, it decreases the quality of vision through the lens. As you're trying to look through a non-wetting lens, we've all experienced, when a patient has a non-wetting lens, it really affects their quality of vision more than the comfort even, I think. Again, a non-wet surface also allows deposits to attach to the surface more easily. This is crystal clear. If you ever have a patient who develops some type of lid palsy, lid paresis, whatever, where they're not fully blinking, you're going to see the lens forming deposits over the surface of the lens where the lids don't close and where they don't re-wet that lens with each blink. So a drying of the lens surface allows deposits to attach. And so by keeping the surface wet as much as possible, we actually reduce depositing on that lens surface as well. And then a non-wet surface also increases friction with the lid wiper when we blink. And that will start the cascade of lid wiper epitheliopathy, which is really a vicious cycle because as our surface is non-wet, we increase friction, our lid wiper breaks down, our lid wiper does a poor job of distributing the tears, which creates more non-wetting, which creates more friction. And it's just this cycle that goes on. And to break that cycle of lid wiper epitheliopathy, once it really gets going, is very difficult. So a non-wet surface, other than just creating maybe the symptom that it feels a little dry, has a whole host of other ramifications which significantly affect our patient's wearing experience. So again, what we want to do, we want to create a better wetting surface because that gives our patients better vision. Sorry, my video on the right's not running. A cleaner, less deposited lens, and in theory, then a longer lasting lens. It's also going to create less symptoms of dry eye and triggering that dry eye cascade. And you can just see this is the same patient, exact same lenses. The only difference is the picture on the left. You can clearly see a bit more depositing on the surface. You can also see that tear layer evaporating after 4 or 5 seconds after the blink, as you can see by the reflex on the surface of the lens. The picture on the right, this is a lens that has a coating on the surface to help maintain the wettability. And it's a significant difference in the patient's experience, both in terms of vision and comfort and deposits. So creating that more wettable surface is really hugely important to our patient's wearing experience. How does wetting occur? So I've just taken this video and slowed it down a little bit so you can see. I think we all recognize this, but it's not like when we blink, our lids meet in the middle of our eye. The wetting process, the distribution of tears occurs just entirely by the upper lid moving down across the surface of the eye or lens and pulling the tear meniscus, if you will, and the oils from the lower eyelid and upper eyelid. When they touch, the lids touch, and that pulls the lipids out of the lids. It grabs the tear meniscus that's sitting on the lower lid, and it redistributes this over the surface of the eye. So again, it's really important that the upper lid, and in particular that lid wiper area under the lid, is in good health and is functioning properly, or the lid wiper can be a real source of problems with surface wettability of our lenses. So again, surface wetting, it's about the lens, it's about the material, it's about the tears, it's about the function of the lids. It's multifactorial in how this works. So again, what happens when proper blinking does not occur? And there's many reasons. Patients can have poor blinking habits. We know that some patients who wear GP lenses for years develop an incomplete blink because of lens awareness. And then even when we move those patients into scleral lenses, they've maintained that poor blinking habit. We also know that poor blink function, patients who maybe have had lid procedures in the past and now they don't have a good complete blink, trauma, paralysis, palsy, etc. All these things can occur and create an incomplete blink. And not only that is device use. I mean, patients who are on devices don't often blink fully. And again, what that creates is a drying of the lower half of the lens, the lower third of the lens. And you can see again in this picture, the deposits tend to accumulate much more significantly where that lens surface is not being wetted properly between blinks. So again, proper blinking is a big part of this too. And patients often don't realize they are a bad blinker. They need our awareness of this. They need us to point this out and re-instruct them sometimes on proper blinking techniques. So we're going to shift our attention now specifically for a little bit to contact lens materials, cleaning of those materials and coating of those materials, and how these all work together to impact wettability. And then after that, we'll kind of talk more about ocular health and the impact on wettability as well. So again, how much does the material matter when it comes to wetting? Here's just a picture. You can see 5 different images of varying degrees of free surface energy. PMMA, which was, of course, the lens material we used for contact lens correction for many years before the implement of GP, gas permeable materials. So for many years, PMMA was the go-to material. And of course, PMMA has a pretty nice surface wettability, as you can see, probably why many of those patients who wore PMMA lenses for years loved them, and probably why the darn things lasted for decades sometimes, because that wettability allowed them to stay deposit-free or relatively deposit-free. So again, PMMA certainly had some advantages, oxygen permeability not being one of them, of course. But beside that, it definitely had an advantage on wetting. As you move across and look at the other pictures here, the one that I wanted to point out is letter D, and that's silicone. And what allows our GP materials, modern GP materials, to be breathable is the addition of the silicone, which creates oxygen permeability, but it does so at a price. And you can see what happens with silicone when we add water to it. That wetting angle suffers in the process. So we're fighting that battle of oxygen permeability impacting the lens's surface wetting. Again, as we look at rigid contact lens materials over the years, we started with our PMMA material, and then we moved, of course, to the silicone infused materials, which helped with oxygen permeability, which is very critical, because obviously we know with PMMA is the impact on the health of the cornea long term. So the silicone implementation was important, but it had wettability issues. And so the addition of fluorine into the process, or the fluorosilicone acrylate, which is what most GP lens materials are nowadays, the fluorine helps with wettability of the surface, and it also helps resist surface deposits in the process as well. So again, most of the materials you probably would order for your patients today in 2021 are going to be the fluorosilicone acrylate family of materials. There are different ways to measure the wettability of these materials. One of them being the sessile drop, which we'll talk about each of these in just a second. I'm going to show you how they work. Another one that's commonly used is captive bubble. And then a third technique, the Wilhelmy plate technique, is really not used that much in assessing GP contact lens materials. You don't really see this technique described much in publication. So what is the difference? The sessile drop is simply dripping or dropping a very precise volume of liquid onto a surface, and then watching how that liquid spreads out over the surface and measuring the angle between the surface and the edge of that bubble of fluid. And so this is how it works. And it's easy to perform this given the proper instrumentation to drop a very precise amount of fluid onto the surface. The only negative is that evaporation can occur rather quickly, which does sometimes affect measurability, accuracy of surface wettability using the sessile drop method. So another method which is a bit more accurate and not as vulnerable to wettability issue or evaporative issues is the captive bubble method. And this is a situation where you have a lens material which is actually submerged in water or another fluid, and instead of dripping liquid down onto it in air, you release air up from below it, and the air bubble rises to the surface of the material, and then it spreads out as well, where the surface material and the fluid that it's in will cause the resisting of the bubble to spread. Again, this is a more accurate but harder to perform method, and has its shortcomings, and the bubble release can sometimes be difficult. A third way of doing this that's similar, it's the captive bubble method, but a little different way of doing it is a dynamic captive bubble. And you'll see this sometimes reported in the in laboratories or polymer companies spec sheets. They'll talk about their wetting angle by the dynamic captive bubble. And this is a similar procedure, but we're actually putting air down and then pulling the air back up again. So it's kind of like it's dropping the air and then sucking it back up again, back and forth, and watching how it changes the size of the air bubble as it advances, and then it recedes back again into the instrument that drops that bubble out. Again, more accurate yet more time consuming and increasingly challenging to perform. So again, wetting angles of lens materials, generally speaking, lower wetting angles are better. And so when we look at spec sheets for our various different materials, you're going to see a wide range of wetting angles. You'll see numbers as low as 3 up to numbers in the 40s or 50s. And you'd think, well, gosh, that's a huge difference. Why don't I just want to choose those materials with low wetting angle numbers every time? And the reality is that the different manufacturers are going to use different ways of reporting their wetting angle. And so you may have a situation where one lab presents their wetting angle as 10 using the sessile drop method, and another lab reports their wetting angle as 30 using the captive bubble method. Well, what is that? That's apples to oranges. You can't really compare them side by side. And so most of the time, the wetting angles that are reported are really kind of difficult to understand and difficult to interpret, particularly when you're going across manufacturers. Now, within a manufacturer, so if I'm looking at the chart in front of me here where I've got Optimum Extreme and Optimum Classic, I can look at those side by side, and knowing that they're tested by the same manufacturer and they're using the same methodology, I can trust that there's probably a bit of a difference in those materials, as you can see. But comparing, say, Optimum Classic to HGS 100, I don't really know if that's, a 5-fold difference in wettability, because again, these are different techniques for measuring them. And so again, my personal experience is that with this wide range of wetting angles, you'd think there'd be a dramatic difference, that if I take a lens material that's not wetting and I make a lens out of something that has a better wetting angle, I'm going to see a dramatic improvement, and it just doesn't show up that way in the clinic. And again, I think that's because of the way we measure them is different. And so again, what this comes down to, I think, for many of us, is we get concerned about wetting of the surface, and we start thinking, well, let me try remaking that lens in a different material and see if that'll be better. And the reality is that of all the things you can do probably to impact wetting of a surface, whether it's a material, whether it's lowering the surface tension of the tear layer, whether it's coating the lens, et cetera, I have to say that I think the choice of material is probably one of the least important things in terms of getting a lens to wet. I think that I think if I were going to go to battle and try to improve wettability, worrying about the wetting angle of my lens material is probably one of my lower priorities. I have other things that are much more important for me to look at in terms of trying to improve that patient's wettability. So again, other than the polymer difference, what else impacts wetting with our lens? Certainly lens surface condition is a big one. And that can be anything from, getting a brand new lens from a lab that's still got residue on it, which is obviously going to affect wetting. Having a lens which has got deposits on it because it's an old lens. Having a lens with deposits on it because the patient has severe dry eye and they're not blinking well and they don't wet their lens right. So again, the surface condition, as that lens accumulates deposits and whatnot, or has deposits on them, absolutely affects wetting probably far more dramatically than a lot of the other things that we're going to talk about. So it is important to make sure that lenses that we get from a lab have been thoroughly cleaned. And most of the time nowadays, plasma treating is something that's done on most lenses as a rule. Some practitioners don't prefer it, and that's just fine. But as I'll show you in a second, the scientific data supports that plasma treating a lens does help with wettability, at least at the initial outset. Again, cleaning and conditioning a lens. Some lenses arrive to us already wet. They arrive in conditioning solution, which is great. Some lenses arrive to us dry. And again, those lenses need to be cleaned and conditioned properly before we try to apply them. It just doesn't pay to skip the cleaning and conditioning step, because when we get that lens on the eye, if it's not wetting, that's going to create more of a hassle than it would have been just to clean and condition that lens when we got it. So again, years ago, when I was much younger and probably a lot better looking back then too, I had a workshop where I talked about fitting scleral lenses, and this was years ago when they were relatively new. And I had a senior doc in the room who talked to me afterwards and said, you've really got to make sure that when you're working with these lenses, you condition them properly. And he said, you need to rub that thing, that the physical rubbing of that lens material with your fingers with a conditioning agent, a surfactant agent, makes a dramatic difference when you put that lens on the eye. And I would say that since 15 years ago, since that, I learned that I never skimp that step of lubricating or conditioning a lens thoroughly, forcefully prior to applying a lens. And I almost never have initial wettability issues like I see with other people or with my students in the clinic when they apply lenses and they shortchange that rubbing and conditioning step. So I would just really highly recommend making sure that any lens you place on the eye has been thoroughly rubbed with a good wetting agent prior to application. And if it's a scleral lens and you need to rinse some of that off, fine. I understand, that makes sense. But I think sometimes, again, we neglect to think about the value of that conditioning step in the wettability of a lens material when we go to put that lens on. So again, wanted to mention the plasma treatment. Plasma treatment is something that's done in the lab. It's the lens is manufactured. It's released from the mold, whatever that holds it as it's lathed, and then it's placed into a chamber with a mixture of ionized particles. Will bombard the surface and remove residual residue and contaminants that might come about through the manufacturing process. And you can see the impact of plasma treating a lens surface after a period of time. It certainly gets away a lot of that extra residue. And the wettability of any lens, of course, like I said, is impacted by the smoothness of the surface. And when we've got a surface which is full of micro deposits or residue, that is going to affect wettability, no question about it. Here's a chart that shows the impact on surface wetting of plasma treatment. When we do run plasma times of at least 50 to 100 seconds, you can see that we affect that wetting angle by almost 50%. We can improve the wetting angle of the surface of the lens from 70 to 40 on a comparable material by doing this hyper cleaning, if you will, through plasma treatment. So I do think it makes a difference. I think it's something that, you know, is probably no reason not to in most cases, unless you have a specific patient who's had a problem with it in the past. Is there any alteration to the lens surface beyond this hyper cleaning? I think most people would say no, but there are publications out there that look at plasma treatment of polymers and note that you can get a silica-like coating that can be detected on some lens surfaces after the treatment, and maybe that silica coating that forms a little bit on these lenses can actually help with wettability as well. So again, I don't know that for a fact. I've not seen enough evidence to suggest that is true, other than a couple peer-reviewed publications that mention it. I do think even regardless of that alteration to the surface, there's definitely a cleanness that comes about through plasma treatment. The next step in the process of getting that lens to wet better, once we've cleaned it well, once we've plasma treated it to get rid of imperfections, then would be to coat it with something that can significantly alter the wettability of the surface, that can lower that can help with the free energy of the lens to allow that liquid to be grabbed and spread out over the surface more broadly. And so a coating like Hydropeg, polyethylene glycol based polymer mixture, which is covalently bonded to the lens surface after it's plasma treated to remove imperfections and to expose as much of the free polymer as possible, then covalently bonding this polyethylene glycol based mixture to the surface, then forms a shield around that lens material, and again allows the liquid of the tears to spread more rapidly and more readily over the surface. And it does reduce wetting angle dramatically. This is just a little video showing the impact of doing a sessile drop test on a GP lens on the right that doesn't have any coating. This is just a standard GP lens. When we do put the HydraPeg coating on it, a dramatic difference in how that liquid spreads out over the surface. So there can be no question about the fact that coating that lens surface has a dramatic impact on the wettability of the lens. And here's just a couple charts that talk about that. Your chart on the left, which talks about wettability. The key take home of this chart is really the first two columns. A silicone elastomer with a contact angle of 100, applying the HydraPeg treatment to that silicone elastomer lens reduces the wetting angle from 100 to 25. So you have a fourfold increase in the wettability of that lens surface. So again, no question at all that adding this surface coating over the GP material has dramatic impact on wettability of the lens surface. And because of that, it also coincides that we also significantly improve lubricity. And of course, lubricity is the propensity of the lens to not create friction between the lid wiper and the eye. We talked about how important it was to keep the friction to a minimum. And again, the HydraPeg has a significant improvement in lubricity or reduction of friction between the lid wiper and the lens itself as that individual blinks. So no question at all that wettability and lubricity is significantly improved with that HydraPeg coating. What about depositing? We talked about the fact that when you keep a lens surface wetted and coated with something that has a better wettability, you're going to see less surface deposits. And you can see again, this is an example using just a soft lens material, but again, a significant 50% or more reduction in protein deposition. As we look at the picture on the right, this is an example of a scleral lens that is dipped in a black colored lipid and then rinsed in liquid or rinsed in water. And when we have a lens that is not coated or plasma treated, you see that that lipid does absolutely stick to the surface of the lens, because even as we rinse that lens in liquid, the black lipid stays attached to the surface. However, when that lens has been coated with the polyethylene glycol surface treatment mixture, it resists the deposits from sticking to the surface. So both in terms of protein deposition being reduced, lipid deposition, it's just, again, it's like coating that lens in a barrier to surface deposits, which again helps wettability, helps comfort, helps vision, all of it. So again, just a couple examples of some photos, a picture on the left of a scleral lens without the HydraPeg coating, the picture on the right you can see with it, much more even distribution of the tear layer. It's spreading much more nicely over that surface between the blinks. Again, here's our video again, showing the picture on the left of a standard scleral lens without coating, the picture on the right showing with the HydraPeg coating. Again, I forget, I think at one point I timed this video on the right and the individual goes 45 seconds without a blink and it really maintains the surface wettability even still. And this is with a patient with severe dry eye disease. That's why they're in scleral lenses. So some of the questions that people ask is, well, how long does this coating last? Does it come off? Is it permanent? Can it be removed? And the reality is that it is a permanent bond, but with normal wear and tear, handling of the lens, rubbing the lens across contact lens cases, things like that, it does seem to reduce the efficacy of the HydraPeg over months and months of use. We do seem to see that over time, patients would report maybe the initial benefit slowly deteriorates over months and months of use. And so there's now a product available to do an in-home surface retreatment or recoating or repopulation, if you will, of that PEG-based polymer so that patients can maintain the full effective coating over the lifetime of their lens rather than having it slowly erode over months of wear. It is important with the HydroPeg coating that we use approved cleaners. We're not going to use abrasive surface cleaners. We're going to stick to non-abrasive cleaners, peroxide-based systems, or and not using any harsh chemicals for cleaning, such as Progent. And of course, harsh cleaners, abrasive cleaners, harsh chemicals shouldn't be needed because that surface coating is going to keep the lens, in theory, from building up deposits so significantly. So there should be no need to use these strong cleaners and abrasive cleaners on a lens that has the coating. So again, mentioned the Boost system. This is something that's relatively new. It's a monthly in-home treatment by prescription through providers. It's very similar, again, if you've used Progent before, where you've got a special case, you put the lenses in the case, and you're going to combine 2 vials of fluid into the case, let it sit for 30 minutes, then run it through your typical cleaning regimen. And that's, again, going to repopulate the coating on that lens where it may have eroded a little bit over the time that the lens has been initially treated or since its last Boost treatment. And this is just, the feedback I got from a patient who I had put on Boost. I've had probably, I don't know, gosh, 20 or 30 patients now in the last few months that I've put on the tangible Boost. And a lot of these people are dry eye patients. And, so I asked for some feedback, and this was a gentleman with pretty significant dry eye. And just his feedback was he definitely noticed a significant improvement in his lenses by adding the Boost to the system, kept it more comfortable, kept it less dry, definitely wanted to continue using it. And so again, subjectively, our patients are going to typically notice improvements in end of day comfort and vision, et cetera, with HydroPeg coated lenses. So talking briefly about care of lenses and wettability, we talk about cleaning the lenses. We want to be careful of the products we use. When we talk about keeping the surface wetted and surfactants, there's 2 types of lens surface issues that I would kind of break things down into. There's what I would call the acute non-wetting, and this is really the non-wetting that occurs when a patient first puts the lens on. So you put a lens on and immediately it's not wetting, okay? That's clearly not a situation where the patient just has dry eye and, over time the lens doesn't wet because it gets dry and whatnot. This is an issue with either handling the lens, with not cleaning or conditioning it properly, the patient's using products around their eye perhaps that affect it, et cetera. So managing an acute surface issue, I think, is different than a chronic surface issue. And the chronic surface issue is more, that the patient is good with the lens for the first hour or 2, whatever, and over time that lens dries and the surface gets foggy due to non-wetting. So some of the basics of cleaning lenses we should talk about. One is, we need to remove loose and bonded particles. This requires a rubbing step, really. There's lots of components to the tears that can accumulate on a lens that do not help the wettability over time. And so we do need to make sure we do a little bit of rubbing to get these components off. Cleaning basics, so there's a lot of different types of cleaners, and ultimately you're going to need to use something that is safe for the lens surface. Again, you're not going to use strong cleaners with a coated material, but with non-coated materials, you can use stronger lens cleaners. I think it's important to recognize something, and that is for those patients who are building up deposits on their lens heavily, regularly, where you're using very strong cleaners frequently, whether it's alcohol-based abrasive cleaners, enzymatic cleaners, Progent, just really strong cleaners. If you have patients who need those cleaning agents regularly, frequently, you need to think about the fact that why are these lenses getting so built up? And you can say, well, the patient has, really horrible tears, et cetera. And I would say to you, it doesn't really matter how bad the patient's tears are. If the lens is staying wet on the eye, you're not going to build up these deposits. And so I would go back to the idea that as we think about cleaning, that's great. We definitely want a clean surface. We know a clean surface matters. But keeping the lens clean is not the end all and be all. The first part of that is to never let the lens get that dirty or build up, because we've maintained a wet surface while the lens is on the eye. So that goes back to, again, managing the patient's disease. Again, I'm not going to go into a lot of this. There's lots of cleaners out there. I don't really have time to talk about them. If you want more information about cleaners, we can talk about that. Again, using the strongest possible cleaner as necessary for some patients is certainly important. Using these products can definitely revive a lens which is in bad shape. But again, the frequency with which we use those shouldn't be that often, unless, again, our patients not keeping their lenses wetted and buildup is occurring. The key component for a lot of this in terms of wettability is thinking about the wetting agents. These conditioners that we use with our lenses, they have wetting agents in them. And I know that in a lot of ways, we love to use peroxide-based systems because they're so wonderful at disinfecting, which is true. But personally, I think they lack a lot when it comes to the amount of surfactant that's on the lens surface and the conditioning of the lens that occurs. I would, in general, prefer to use a GP-based solution that's approved for GPs for cleaning and wetting, because I think in many cases, those solutions do a better job of helping the lens to wet better. And again, a lot of these multi-purpose solutions, non-abrasive cleaners like Unique pH, like Boston Simplest as mentioned, are approved for use with the coated HydraPeg lenses. Also want to mention the Tangible Clean, which is another solution. One of the things I really like about Tangible Clean is that, for example, I just had a patient yesterday who we dispensed a new set of lenses to, and her history is that of soft lens wear. So she's always worn soft contact lenses, her first foray into scleral lenses. And so she's always used a multi-purpose solution. And as you know, when you're dispensing new lenses to a patient, sometimes the cleaning part gets to be hard to, one more thing to remember, and the patients do it wrong. So the thing I like about this is for patients who are used to using multi-purpose solutions, the Tangible Clean works great. It's thinner, it's easier to remove than a GP-based solution, which is thicker, and it also is compatible with the HydraPeg coating. So that's another nice aspect of the clean. Again, peroxides, really great for disinfection. They do have a surfactant in there. I don't know how well that surfactant serves us on a GP lens, to be perfectly honest. And there have been studies that show that digital rubbing with peroxide is still important, that not rubbing the lens doesn't really get rid of surface deposits. So again, when it comes to cleaning and storage, make sure the patient's using proper cleaning agents. Many times the patients who come in with wetting issues, when we sit and go through what's your care regimen, et cetera, we find out they're not doing something right, or they're not rubbing their lens well enough, or whatever it is. And sometimes they're just doing things wrong. And so the first step is always to make sure we're doing things right with cleaning and storage solutions. If everything's going right with cleaning and storage solutions, the patient's cleaning their lenses properly, you've got the lenses fitted well, maybe you've even got a surface treatment on it, and you're still having issues with wettability, then we need to go back to the patient's ocular surface and think about, why is this lens not wetting? And so I want to briefly go through the wettability factor that is related specifically to patients' ocular health. Again, it's important to note that water has a surface tension up around 70. The normal tears of the eye have a surface tension somewhere in the upper 40s, so it's significantly different. What's interesting, when you look at patients with dry eye, that surface tension is higher. It's elevated in dry patients to more closer to the low 50s. So that patients with dry eye will have a natural tendency to not wet their lenses as well, because the surface tension is altered in a dry patient. So this is, again, an important reason to manage really all of our GP patients as potential dry patients. Adding lubricant drops certainly helps. Lubricant drops definitely help wetting. They have surfactants, they have lubricants to help with reduced friction. So it's important. We also need to make sure, though, that we use the right viscosity drops. Too high viscosity creates blur and foreign body, and too low, it doesn't stick around. So making sure we try to get the patient with a proper viscosity drop helps. I just have a couple cases. This was a patient who came in a few years back, 53-year-old female. She had been seeing another practitioner at our clinic, had issues with the lenses getting, non-wetting. They had tried ordering her new lenses twice, switched her cleaning solutions, et cetera, et cetera. I got to see her one day for a dispense on a lens, put it on, non-wetting, really bad. Flipped her lid, and you can see, literally 4+ lid wiper epitheliopathy that's confined to the section of the lid wiper which rubs over that plastic surface 10,000 times a day. So again, there's no question that the friction associated with the lid wiper rubbing over the surface of a GP lens can create lid wiper epitheliopathy. Another thing that is interesting, again, is the blinking that occurs. And here's just a slow motion video of a GP lens wearer with their lens on. And you can see by the blinking that they don't close their eye fully. This patient closes, about 80% on average with their blink. And that's an adaptation that people will develop to reduce the sensation of their GP lenses. So again, making sure patients understand they have compromised blinking, try to get them to address that by taking better blinks. Again, with our corneal GP lens wearers, really re-instructing proper blinking. I don't think there's anything wrong with it. Tell the patients to blink their eyes completely shut. And Dr. Shendowich in Israel has this great little quote about setting aside time to practice blinking, helping. Again, I think this is absolutely critical that our patient understand the importance of a good quality blink, and that when they're on devices, et cetera, they're not going to blink. It's going to dry the surface. It's going to affect wetting. They're going to get buildup, et cetera, the vicious cycle. So instructing patients on proper blinking, it sounds condescending, but it's absolutely critical, and most patients are unaware they're not blinking well. The impact of scleral lenses on wetting. This is another patient of mine. The picture of the eye on the left doesn't wear a scleral lens. They've had a corneal graft and they see fine without anything. The picture on the left, they wear a scleral. You can see the impact on the lid wiper from scleral lens wear. I think it's also interesting to note that when we put a scleral lens over a patient's eye and we tell that eye, we trick that eye into thinking that it's wet with the tear reservoir, what happens to basal tear production? It tends to diminish, and that again, you're cutting the tear layer, you're increasing the propensity for non-wetting to occur. We also want to recognize that putting a scleral lens on the eye props the eyelids open wider. That's been proven, and so that's increasing the surface area of the eye, which is exposed to the environment, which again puts increased demand on the tear layer. You have the same amount of tears or even less because of the scleral lens. And now we're propping the eye open wider, so we have to cover more surface area with less tears. That's going to create a drier surface, and it's going to create friction and again, surface drying. So we need to remember that. Scleral lenses absolutely increase friction on the lid wiper. They've decreased basal tear production. They increase aperture to stress the tear layer. And so again, all of our patients who wear scleral lenses, I just treat them all like dry patients. We lubricate with lenses in place frequently, every 2 hours, every hour, whatever it takes. We manage these patients as dry patients, keep the vault low. And again, the coating on the surface is just really absolutely critical. Most of our scleral lens patients and many of our GP wearers as well benefit from that PEG coating on their lens surface, and boosting it helps as well. So just to wrap up this 50-minute time, and then we can take some questions. I think summarizing wetting of GP lenses, I think a lot of times people see a non-wetting issue and they think that it's the material's fault. They think the lab blew it on that one. They did a bad job. They overheated or something. They think the patient's not cleaning it well enough, so let's put them on, some kind of industrial strength cleaners, et cetera. And a lot of time, I think it's really the patient's bad habits. It's their dry eye disease or it's lid wiper disease that's catching up with that patient over time. So it's important to talk about proper care with the right solutions and the rubbing step if there's issue with buildup. I think we manage patients' bad habits like their poor blinking, their improper care regimen. As fitters, we need to make those lenses as comfortable as possible so the patients don't have to develop an adaptation that alters their natural blinking, because their lenses, they're aware of them and they don't want to blink completely because I feel the lens the more I blink. So I partial blink. We want to avoid that. So make the lenses really comfortable so the patients don't feel them as much and they don't have to adapt. Adding lubricants and surfactants to the patient's daily routine is helpful. It's going to reduce the friction. It's going to coat the surface. It's going to, again, help with surface wettability. There's no question about it. There's no question at all. When you add a lubricant drop, you reduce the surface tension of the tear layer and you create better wettability. Plasma treating lenses that are new is always a good thing. Again, unless there's a specific reason, if patients had a bad experience or something, fine. But I think for me, I plasma treat probably 99% of lenses that we make because we want to make sure they're as clean as possible right out of the gate. Surface coating with HydraPeg will absolutely significantly lower that wetting angle, reduce friction, spare the lid wiper health. That is the number one thing that I do when I see lid wiper epitheliopathies, make sure their lenses are HydraPeg coated. So again, we're putting the HydraPeg coating on a significant percentage of our patients' lenses. Again, only in those circumstances where a patient's a long-term established wearer that is doing really well and doesn't want to change. In those cases, I might not, but most of our patients we do. Don't forget to maintain that coating with Boost. My experience, again, is most patients find that the Boost definitely helps that surface to be repopulated with that coating to keep the wetting and lubrication factors up. And then aggressively treat dry disease and lid wiper epithelia when found. And that is what I have, Stephanie.